So TMAR and MAI, Chantel and Dave have a pretty good case for us this morning. Chantel, would you mind just kind of reading the case out loud, and then we'll take any questions about, further questions about this case?
Sure. So patient's 59. She doesn't really have any significant past medical history, has like a remote history of asthma, who originally went to an outside hospital because of like some upper respiratory symptoms, like congestion, shortness of breath, and was diagnosed with pneumonia. And then was discharged on like oral antibiotics, and then had a couple weeks later had worsening with nausea, vomiting, poor PO intake, and went back to the outside hospital. It was actually found to be an acute renal failure. Meds wise, she doesn't really take much. She was like pretty healthy otherwise, but she was taking some ibuprofen during that like couple weeks time in between the two admissions. Otherwise she takes like PRN and albuterol. And then social history, she's a physical therapist. She's very active. Nothing really notable in the family history. She's a niece with lupus, and her mom has dementia as well. But otherwise, she's like a pretty good historian, very with it.
All right. Anything crazy on vitals, maybe? We'll just throw them up here for now.
Yeah, so her vitals were very normal. She never...
That's cool. We can just keep them if they're totally normal. We good? Yeah. We don't even need to go into them.
Perfect.
Perfect. Make it easy for you.
Do you want me to go into labs and stuff? Or?
Let's see if anyone has any clarifying. If they want to know anything else about the history, any specific questions. I think before we go into labs.
How much ibuprofen was she taking?
So she said she was just taking like 2 to 3 pills a day intermittently over a couple of weeks. And I think she was a pretty reliable historian. So for Joey's question, she did not tell me that she had any epistaxis, no rashes. And then for Candace, she didn't have, besides this like pneumonia that she did not have any other preceding viral illnesses. That we know.
Where exactly does she work? Like, is she exposed to sick patients? Or is she like an outpatient PT?
She's an outpatient PT. So I don't think she has a lot of exposures.
Did they diagnose the pneumonia just because they saw it on a chest x-ray, or was she having symptoms?
She was having symptoms. That's why she originally went in, and then they diagnosed it based on imaging and like her clinical symptoms.
Good questions.
So the pneumonia, there was about 3 weeks between the pneumonia and the acute renal failure admission. And a week after the pneumonia, she was completely fine. And then that's when she started developing these symptoms of the like nausea and vomiting.
Any COVID exposures?
No COVID exposures.
And didn't the team there think it was like I think she, on the first admission, right, she had a little bit of AKI, but they thought it was like contrast-induced nephropathy, right?
Yeah, so the first admission, they actually did a CT chest to like evaluate her. And it was with contrast, and they discharged her with a creatinine of 2, and they just told her like, that's fine, her baseline's normal. And they said it's probably just from the contrast. And then she wanted to be transferred because her husband loves Jefferson and had all of his care here.
Looking at Fred in the chat. Put it on Bluetooth.
It's actually blue one too, Fred.
All right. Any other questions before? I think maybe we'll say what would just your guys' general workup for any AKI be? And I think that's what we'll give you. So nothing fancy, just general workup for pretty much any patient. All right, so we got BMP, renal ultrasound, urine lights. I guess maybe Chantel will do the BMP first.
Sure. From what, hold on, wait. She had a metabolic acidosis, her bicarb was 15. This is at the outside hospital, so I just have like the most notable things. This is her like acute renal failure admission. Her BUN was 91 and her creatinine was 9.0. My baseline is normal.
All right, and then all the other ones were just normal.
Yeah.
Perfect. And then let's go. Did we ever get like a FINA?
They did not do that at the outside hospital.
I think we had one here, right?
Yeah, let me check.
I think it was about 10%.
Okay.
I looked a little bit this morning. All right, FINA, and then UA. What did UA show?
I think she had 2+ protein.
UA 2+ protein. And then it was like 2 to 3+ blood, right?
Mm-hmm.
Okay. Any casts? I don't think I didn't see any casts. Is that right, Chantel? No casts,
Yeah,
right?
I'm looking at it now. There was
No
no cast.
casts.
No casts. Great question. And then what about a renal ultrasound? Anything with that?
They did a renal ultrasound and we did one as well, which showed no hydro and renal parenchymal disease.
Okay, so no renal parenchymal disease.
No, it did show renal parenchymal disease.
Oh, it did show.
Yeah.
Could they, if we know she didn't have any CKD, did it show any signs of CKD, small kidneys, more? No,
Nope,
no signs.
normal size. Nope.
No. All right, so maybe let's get a couple differentials, and then I think what me and Navi were saying we'd have we'll do like top 3 differentials, and then we'll have everyone break out, and then they have to they have to talk more about the differential, what adds up, maybe what doesn't add up. So yeah, just a little too different, and I'll add it in. So what kind of things is on your mind right now? Or what kind of things do you guys think this could be? All right, so we have 1 vote for GN. We got some dittos. AIN.
Sexy. Real sexy.
And then, do we have a third?
Let's say they were right about the contract. Oh, there we go.
Perfect. All right, so I think we got our top 3. So let's break you out. I'm going to give group number 1 is going to be glomerulonephritis. Group number 2 is AIN, and group number 3 is ATN. So I think what we'll do is when you present your diagnosis, present what fits, and then present what doesn't fit. And then should we do further workup as well?
Yeah.
And then present further workup as well. So what fits, what doesn't fit with your diagnosis, and then further workup. So GN is group 1, AIN is group 2, ATN is group 3. Let me put you all in the breakout rooms. So 3 rooms. All right, can everyone see the rooms? Maybe you can see when you go in there. Yeah, no, but I want to. Can they see when they go into the rooms, what room they're in?
Maybe. I think maybe.
All right, well, just take a look here. Remember what room you're in case you don't know, so you know what to talk about. So remember, glomerulonephritis group 1, AIN group 2, ATN group 3. And I'll see y'all in 5 minutes.
never enter rooms?
I know, me neither.
That's a good question. I don't know.
Am I going into a room too?
No, it's all good. You can. Yeah,
No.
I think I just can't not put you into a room, but yeah, just.
We prefer you to float around in the ether that you're in.
Perfect. That's where I live.
Yeah, it's nice. Real nice. I am assuming when you do the glomerulonephritis, you're going to do the little like. I'm assuming,
Yeah, I always.
GBN.
Sometimes I don't know.
What do you do? AKI-GBN complement?
This is the one I have. We're gonna talk about that. We're gonna talk about that. This is one I have that I.
This is exactly how I do it.
Yeah. This is how.
Yeah, I literally said AKI.
This is how the Orange Book does it.
Oh, good.
Yeah. But then I added. You like this?
Yeah, no. you
That's
should.
kinda nice.
I do really
That
like
is nice.
Right? Adds the histology in there.
Yeah.
I was pretty happy when I thought of that one. But I don't know if I was just gonna do that or I was gonna draw it out, maybe with the kidney glomerulus and like do it like a maybe I can't actually. No, I can't. I didn't put that in there.
What?
The thing I want to do is like maybe we'll do speaking about like diagnostic adequacy. Maybe we do chest X-ray, infiltrate.
Yeah.
Acute renal failure. Oh, and then she did have to. Oh, I forgot to present this. Systemic signs and symptoms. And then, like, which one hits all of these? What specific disease?
Yeah. It's like trying to present medical, like your reasoning.
Yeah.
Yeah.
The constellation of symptoms. Yeah.
Yeah, and like, which one hits all of these? Because this does hit all of these.
Yeah. I mean, she has, like, in retrospect, she has a pretty typical case of, like, the granulomatosis polyangiitis.
Yeah, and then she had epistaxis when she came in here, right?
So she didn't tell Chantel that initially, and I guess didn't really tell the other hospital other than, like, the stuffy nose. But I guess yesterday, either rheumatology or somebody, when the ANCA came back positive, must have asked her, and she said, yeah, I've been having epistaxis.
Yeah. Crazy case.
It's actually the second Wegner's that I've seen.
Yeah, I've seen it 2 or 3 times as well. More common than I guess we have a bias too because we always get those transfers.
Yeah.
You know what I mean?
The other one though was actually a very similar one in that it was somebody that like got diagnosed with a pneumonia, treated with antibiotics, and then ultimately ended up being probably just, or for him it was alveolar hemorrhage.
Yeah.
For her, probably she never had a pneumonia. It was just hemorrhage.
Yeah, exactly. Crazy. Crazy.
I think Chantel probably went into a breakout room.
Oh, she did? Okay. That's all right. I don't know.
Damn it, Chantel.
Maybe I delete this one. I don't know.
Which one?
This one. Just do this one.
Okay. Yeah. Then you won't have time for your infiltrate.
Yeah, I'm trying to do too much, I think.
I think we already went past this. Or nah, just do the nephron.
You think just that, Fran? All right.
Yeah. You can probably just show them the final product of this.
Yeah, but now I don't have it anywhere.
Oh, okay.
That's all right, though. I think I can do. Let's just try to do both. We'll see.
It's just presenting it in 2 different ways. So maybe show the nephron first, and then if you have time, go into that.
That's a good idea. I like that. All right, that's
Okay.
perfect. Yeah. All right, want to break them out? Close all rooms. What do you think?
How much time have they really had? 4 minutes? 5 minutes?
5 minutes maybe.
Okay. When you
Yeah,
do
probably
closing-
about that.
That's probably good enough, right? And then it takes them a minute to come back to.
Yeah, we'll give them 805. 805. They get grumpy when you close them out too early.
Yeah, they're learning. They're learning right now.
They're learning. They're talking. I hope they're talking.
They're jamming. They're slamming.
Doing it all.
They're beeping and they're bopping. Oh God. Uh-huh.
I can't believe my computer didn't break yesterday when I was doing that. It was
I can't
like,
imagine what was going on.
worrying. I was like worrying the entire, like, it was like a,
Why? It's
just on its
fucking
last
PowerPoint.
breath. I don't know. It was like PowerPoint and the Zoom, and then also
What
I
a
had like
shitty computer.
6 YouTube videos up.
Well, our laptops would be able to handle it.
All right, we all back? Who wants to go first?
We tried to open it up.
The one thing I'm just going to go through, I think, as we talk about this is the way I think about intrinsic renal disease. I think about really the glomerulus, and the nephron itself, and I think about, you know, where each of these things kind of attacks the glomerulus and the nephron. So one of the first things, at least when you're looking at the nephron that it can attack, is the microvascular. So things that actually cause, you know, clotting of the microvascular, it's going to be your microangiopathic hemolytic anemias, things like TTP, DIC, HUS, right? So it's kind of one of the first things that I really think about when I'm thinking about intrinsic. So that's one. Number two is things that affect the glomerulus. So, I mean, obviously it's going to be your glomerulonephritis, and there's a huge differential even for that as well, that we may or may not go into in this case. Number three is going to be things that affect your epithelial, like tubular cells, right? So that's going to be your differential diagnosis of ATN. So that's going to be number three. Four is things that affect your parenchyma, and this is going to be acute interstitial, so it affects your interstitium nephritis, causing inflammation of the interstitium, and actually damages the renal tubular cells as well from that, but we'll go into that. And then lastly is going to be anything that just like obstructs the nephron. And when I think about things that obstruct the nephron, you know, I think about multiple myeloma, I think about crystals, which can be, you know, ethylene glycol, it can be methotrexate does this, uric acid, et cetera, et cetera. So it's kind of the way I think about intrinsic renal disease, and that's kind of how I guide my differential. Everyone does it a little bit differently, but something that we maybe just be talking about a little bit going through here. And I think we're going to try to touch on how to discriminate between these and what are some helpful things and how helpful are they? What is the evidence behind using a UA? What's the evidence behind looking at granular casts and things like that? Are these helpful, or, you know, should we just be nihilists and say nothing's helpful for, you know, differentiating between different causes of disease? So anyway, let's go group number one. Well, this is GN. So what fits, what doesn't fit? What do we want to do?
All right, this is Andrea, Christine, I think Tina's in there. It went down again.
Okay, I can talk about it. What my group talked about.
Hey, Tina.
Hey, so there are a few things that we thought fit well with glomerulonephritis. The fact that there are multi-organs involved.
Nice.
So we were thinking like maybe a systemic like vasculitis could potentially be contributing. The fact that there was blood and protein in the urine analysis. She didn't have any other symptoms like swelling or hypertension that sometimes we see, but potentially they were missed. So under that, I mean, there are a ton of differentials under glomerulonephritis. Some of the ones we talked about were like IgA nephropathy. We talked about granulomatosis with polyangiitis, and see what else, like lupus. Yeah, potentially like a hepatitis B associated disease. Yeah, those are.
Perfect. And then
Overall,
one of the things I really like is so glomerular basement membrane. It's something we didn't go too much into, but she did have some systemic signs and symptoms. She had an elevated ESR, an elevated CRP. She had general malaise, I think, as well, and like kind of like feverish for over a couple of weeks. So going through these different vasculitides, exactly what Tina was saying, causes of glomerulonephritis. Lupus and like a primary vasculitis will cause systemic signs and symptoms, but actually glomerular basement membrane disease does not. Actually, these patients may feel pretty much fine other than having diffuse alveolar hemorrhage or having acute renal failure. So that's kind of one of the things that can help you differentiate when someone has acute renal failure. Could this be a vasculitis or could this be glomerular basement membrane disease? How about for a chest x-ray infiltrate? Do you guys think that vasculitis can do this? Yeah, Tina's saying, yeah, exactly. Yeah, it can. It's a multi-system disease. Same thing with lupus. Same thing with glomerular basement membrane. Infectious glomerulonephritis like Hep B, Hep C. Actually, staph is more common than strep now, which is kind of interesting, just with IV drug use. But that, unless they have IV drug use and they have septic emboli, it's kind of hard to say that will have it. And then obviously all of these can cause acute renal failure. So perfect. This is kind of the differential diagnosis for glomerulonephritis here. But it's the one that's in your orange book, and it's kind of the one that we went through. And this is the way I think about my approach to glomerulonephritis is, you want to test for ANCAs. C ANCA is usually going to be GPA, while P ANCA can be microscopic or eosinophilic. Granulomatosis with polyangiitis. You want to test for an glomerular basement membrane, and that it's always going to have kidney involvement, but it can actually have, it actually can be without lung involvement. So without lung involvement, it's just called anti, but with lung involvement, it's called good pastures. And then exactly what Tina was talking about, there's your infectious and your other autoimmune glomerulonephritis like lupus and post-strep glomerulonephritis. The way to differentiate these is actually going to be your complement level. So all these are going to be type 3 hypersensitivity reactions. So there's an infection, there's an antigen floating around in your body, whether that's Hep B, Hep C, or it's your body attacking those antigens. Okay, I'm going to move you real quick. Or it's your body really attacking your ANA, your anti-double-stranded DNA, and then those complexes are going to bind complement, and they're going to basically bind to your glomerular basement membrane, causing an inflammatory infiltrate and glomerulonephritis. Because IgA doesn't fix complement, and also because this is a more indolent disease, your complement levels will usually actually be normal with IgA nephropathy. So let's say we worked all that up as well.
No, I was just going to mention the GBM versus good pastures.
Yeah.
The other thing I guess sometimes we get confused about is like how Alport syndrome kind of fits into it, maybe.
Ooh.
Do you guys know what Alport syndrome is? thin split basement membrane.
Doesn't it affect your hearing?
It does, yes, definitely. So the like triad that I always remember is it has a cochlear injury, so inner ear typically is involved. It also involves your like corneas and your lenses, and then specifically, of course, the renal, like the basement membrane. But it's not an autoimmune disease; it's a collagen defect. So just the kind of like subtle difference there is it's going to be in areas that are going to be predominantly dependent on your type 4 collagen. And so just remember Alport syndrome is very different than Goodpasture syndrome or like anti-GBM, because those two are like more autoimmune diseases, that are going to be attacking the type 4 collagen in your basement membrane. And that's the same place where type 4 collagen is present, but Alport syndrome is a defect in it. So that has like a split thin basement membrane classically, has cochlear involvement and eye involvement as well.
And the last thing I'll mention before we go on is I'm always wondering, how helpful is the UA for these different diseases, right? Like, how much can I prove this is glomerulonephritis, that there's some protein and that there is some blood? So maybe not as good as you think, or maybe better than you think. I don't know. But if there is no blood on the UA whatsoever, then you do moderately decrease having like a proliferative glomerulonephritis, and your likelihood ratio is about 0.2, which decreases it by about 30%. If you have +2, this is kind of easy to remember. +2 blood, your likelihood ratio is 2. +3 blood, your likelihood ratio is 3. The other thing that really helped us in this case too is that there is protein as well. And when there's blood and there's protein, it actually goes up to about 4. So this can be pretty helpful, increasing your suspicion by around like 25%. Someone brought up casts. Now, I think that we are, classically taught in medical school, you see a red blood cell cast, that means that this is going to be glomerulonephritis. And that is true. So, casts are very specific for glomerulonephritis, like 98% specific. So if you see it, it's not going to be anything else. If you don't see it, it doesn't really help you at all, because it's only 40% sensitive. You only see the cast in 40% of cases. So if you don't see it, it doesn't help. It doesn't really help you that much. All right.
Can I ask a question? Sorry.
Yeah, of course,
I don't
Tina.
want to take too long. So, we talk about like blood and protein and the fact that you see in glomerulonephritis because the glomeruli, which is supposed to keep all of those out, breaks down somehow for that barrier. But if you have breakdown like further along the tube, like in the tubules, would you, if it's gotten to a point where all of that's broken down, can't you have like leakage of blood from like the vasorecta and protein just because there's inflammation there? Or is it actually like specific for glomerulonephritis?
That's a great question. And actually, I'm going to touch on all this, but specifically when we go into AIN. Is that all right?
Yeah.
Because you do get hematuria in 50% of cases with acute interstitial nephritis too, for the exact reasons that you just said. So it's not, that blood is not super specific, and I think that's probably why the likelihood ratios aren't as good as you would think they would be. When you have blood in the urine, it doesn't, obviously there's a whole workup of hematuria, but blood in the urine and acute renal failure doesn't always mean, obviously, glomerulonephritis. There's a bunch of different things that it could be. All right, shall we do group 2?
Group 2 is Ashima, Carmine, Kathy, Connor, Dave, not actually Dave, but Joey, Kirpal, and Zach. You guys are supposed to help us out.
Yeah, so a couple of things that we thought went with AIN was the NSAID use. That was the most, I think, like our strongest positive. And then also like the hematuria, proteinuria, some of the systemic symptoms like the fever, things that make it less likely. I guess if we had a little more information about like eosinophilia, like eosinophils in the urine or peripheral eosinophilia, which we don't know, but let's assume that it wasn't there. And then there was no rash. Also, like the quantity of the NSAID use it doesn't sound like she was really using it that often.
Group 2, I guess my question is, you're kind of hitting on some of that stuff, like with, you said, like the eosinophilia, fever. I'm assuming, eosinophilic cast is another thing that you're worried about. Maybe sterile pyuria, all that stuff. How often do you think those findings actually happen in AIN?
Not that
Like
Yeah.
majority of cases, minority of cases?
No, probably the minority.
Right. Yeah, I think it's maybe less than 30% of cases actually have the triad, or like, the classic like sterile pyuria, but it is one of the things that we think about. So when you're approaching AIN, there's a lot of different mechanisms that can cause like acute interstitial nephritis. There's a few like autoimmune diseases. There's infiltrative diseases. There's, drugs and toxicity that can actually be involved in AIN. So, so when we think about some of the drugs, you had mentioned it. So NSAIDs is definitely one of them. What other drugs do we give, like, are we concerned about causing AIN?
EPIs.
Yep, PPI, very classic. NSAIDs, PPI.
Sulfa antibiotics or any sulfa drugs, I guess?
Yep, sulfa
Yep.
antibiotics. And another class of antibiotics as well.
Macrolides, I believe.
Not classically. The one I'm thinking about is
Penicillins,
beta-lactams or
Yeah.
penicillins. So those are, the way I also remember them, and they're also kind of like very allergenic. Like these, some people think that the underlying mechanism is related to allergy to the drug. So that's a great list. As far as infiltrative diseases go, it's kind of a little odd, but what kind of things come to mind? A lot of them are autoimmune too. And I like these diseases.
Lymphoma-ish?
Yes. Yep. Lymphoma, leukemia, both of them actually. So you can have,
Sarcoid?
and sarcoid. Yeah, very good. Yep. All three of those.
And IgG4.
And IgG4, although I guess
It's like autoimmune.
you're right, we think of it.
Yeah, more autoimmune.
Is it?
All right.
And then the last, like, it's kind of a rare one, but we think about like, does anybody know what Tinu syndrome is? It's tubular interstitial nephritis with uveitis, and typically it's bilateral. I don't even know why I brought that up, but I like it.
So obscure. All right, so just going over like how helpful are these things. So one of the more helpful things is actually proteinuria. It's not usually like a ton of protein. It's usually about 900 milligrams is like on average. So proteinuria is pretty common in these cases of acute interstitial nephritis. Really from exactly what Tina was saying, that leakage of protein, that leakage of cells from the interstitium into going into the nephron. White blood cells, which is like our classic, only about 65%. Hematuria in 50%. Peripheral eosinophilia in 35%. Rash in 25%. And actually an elevated ESR in 100%. So these things are really not that helpful. And acute interstitial nephritis is really pretty much a difficult diagnostic dilemma. Does anyone know how you really need to prove it? What test you really need, or test, or what you need to do next?
Biopsy.
Biopsy, exactly. If it's on your differential and you can't prove it, but you cannot prove it, you're really going to need a biopsy. And then granular casts are actually like commonly in acute interstitial nephritis from a recent study that they did, in which it was biopsy proven interstitial nephritis. And I think this is actually, inflammation of the parenchyma leaks over and actually starts hitting those tubular cells. So it's actually in greater than 50% of cases, which is super confusing, and I don't like it, but this is at least what the study showed. All right, and then lastly, let's go into ATN. This is group 3. Maybe Brodsky?
Yeah, so we kind of said, like, I guess kind of just like some of the diagnostic things didn't, ATN is tough to prove sometimes, but like, the FINA was 10%, so that's kind of consistent with intrarenal. There was no like obstruction. She's like had some kind of recent like, you know, illnesses, medications, like a lot of things that could cause ATN. So it was kind of just like putting those things together that just like could raise your suspicion, though. I don't know if there was like one thing to hang your hat on that could say like it's definitely ATN.
Sure. I guess. And then that's what you had.
I was just thinking, like, when I think about ATN, it seemed, at least like very early on in my medical training, I was thinking, you know, what is ATN? How does it work? The two things that I think about that kind of contribute to ATN is anything that can cause like pre-renal injury. Like if you let it go on for a long enough time and it causes like ischemic damage to the kidney, that can cause ATN. Or if you have any sort of toxins that are causing like direct like damage to the tubular cells, can cause ATN. So maybe thinking about those two like underlying mechanisms, we come up with a list, right? So anything that can cause ischemic injury and then anything that can cause tubular damage. So Nick is pointing out and highlighting some of the kind of,
Oh, I just did that wrong.
okay. But so thinking about those things, ATN can happen from, for example, sepsis, right? So that's going to be ischemic injury, like hypovolemia, any type of hemorrhagic, like, or really any type of shock, period. If you let it progress over long enough time, it's going to cause ischemic damage to the tubules. And then when you think about like toxins, there's just like there's like a kind of a list of drugs that we worry about causing AIN. Can you think of some of the drugs that can cause ATN, classically? Or disease processes, right? There's those, there's kind of, I guess, an infiltrative disease that we think about here too.
For some reason, I feel like NSAIDs can also cause ATN, not just AIN.
Sure.
I think through, yeah.
It is one of the things we worry about, because the underlying injury that we also think about NSAIDs causing, not just AIN, is decreased renal blood flow, right? And so that's progression of ischemia. So that falls under, you know, one of those causes, sure. But what about like direct tubular toxicity? One of them.
Glycoside?
Yeah, aminoglycosides. It's
Azocin?
Yep.
Vancomycin.
Yeah. It's a good list. Cisplatin is another one.
And
Great.
I kind of divide it up into, you know, exogenous things and also endogenous substances. What kind of stuff that can your body make that can actually damage your tubular cells? Maybe I have someone that was found down. They had
CK under dialysis.
Yeah, exactly. Pigment, right? So pigment, so CK, myoglobin, or, you know, even hemoglobin. And I think the one that Navi was getting to is, and this can cause kind of obstruction, or it can also cause ATN, multiple myeloma. So going through just the UA for ATN, how good are granular casts? So actually pretty good. So no casts, no granular casts, actually likelihood ratio of 0.2, so you decrease it by about 30%, which I think is pretty good. Greater than 10 per high powered field basically proves ATN. That has a likelihood ratio of 10. So looking for cast, the absence of presence is very helpful for ATN. There's a lot of reasons actually in this case why this is not contrast-induced nephropathy that they originally thought. And kind of on further review, it didn't really seem like it was. On further review, like when looking at contrast-induced nephropathy, like it definitely wasn't. So acute renal failure only happens in contrast-induced nephropathy, if you believe in it, less than 1% of times. So this patient had acute renal failure, that's not consistent. Also, you really only get contrast-induced nephropathy if you have CKD. This patient did not have CKD. And contrast-induced nephropathy is usually gonna have granular casts. This patient also did not have granular casts, and it's not going to have protein. So you shouldn't have much, it's an ATN, you shouldn't have much, much protein in contrast-induced nephropathy. What she had 2+, but when we actually did, she actually had 3 grams on her protein creatinine ratio. So I think that's kind of why it's not contrast nephropathy. I think it's a good case because it shows a lot about, unfortunately, clinical reasoning, and it's easiest to learn about clinical reasoning, I think, when the other people didn't have the correct diagnosis. And the things, like, there's certain terms that I always like to think about with clinical reasoning, and one of them is diagnostic adequacy. So, you know, their diagnoses in this case, I don't think had diagnostic adequacy, in which this doesn't always happen, but one diagnosis explains the entire case, right? Things didn't add up. She's healthy. She's 59 years old. Why is she getting pneumonia? Is the first thing that kind of threw me off. The second thing is the contrast-induced nephropathy. You usually need to have CKD. Usually doesn't cause acute renal failure. Is the other one that I think was kind of like difficult in this case as well. And then at the same time, her urinalysis being dirty, not being bland, not having evidence of any, not really having any evidence of ATN was another thing that really didn't add up in this case. So I think the diagnosis that they had early on did not have diagnostic adequacy. And I think when you think about cases, there's 2 types of reasonings: intuitive reasoning, and then there's analytical reasoning. And if, you know, we usually use our intuitive reasoning, which is like, you see something, you know what it is, you say, this is that. But if anything doesn't make sense, go back to your analytical reasoning, draw out flow charts like this, start thinking about what could this be, what am I missing? The other concept is diagnostic coherency, in which, and this is that, you know, whatever the diagnosis is makes sense from a pathological basis. And that's another way to think about clinical reasoning as well. So maybe we'll actually get to what this was, and then maybe this will help summarize these whole terms. And I think the thing that this has a ton of diagnostic adequacy, and it explains everything, which is why this makes such an interesting case. So Chantal, do you want to wrap it up for us?
Sure. So the outside hospital lab did come back with her having a positive C-ANCA. And then upon apparently, well, I know Nat saw her on consults for room. And the med student apparently took a very thorough history, more than I did, and found out that apparently she had, like, in the last year, a lot of nosebleeds. And she had some sort of like ear surgery a year ago. So she did have a lot of like ear and nasal involvement. So they started her on pulse dose steroids, and she's currently getting a renal biopsy right now.
And the thing that we were talking about is now going back to the case and looking at it from the fact that we have the disease, everything makes sense. She showed up with worsening shortness of breath, so she probably had involvement of her lungs from C-ANCA vasculitis. She may have had that specific granulomatous masses, or she could have a little bit of diffuse alveolar hemorrhage or pneumonitis. She had that stuffy nose. The chest X-ray infiltrate was, you know, what we were all talking about. Wasn't pneumonia. It was either a little bit of diffuse alveolar hemorrhage or some pneumonitis. She had some upper tract signs. She had acute renal failure. She even had nasal and ear involvement looking back. And then the other big thing is that she was one of the things that I think increases your suspicion of rheumatological disease. It can happen to normal, healthy people. And she was a very normal, healthy person that didn't have any risk factors for getting contrast-induced nephropathy, for getting ibuprofen-induced, AKI. So I think that was, looking back at the case, something else that kind of put all this together. So great case. I thought it was a really good one to talk about. And great job by the MAI and by the TMAR. So,
yeah, this was a pretty interesting case. Just one last thing, because if you I recall taking like a very detailed ANCA history for her. She also had like a mononeuropathy in her foot, and some of the other symptoms were like obscured because she has asthma, and she had some asthma attacks. So that's why initially she was thought to have shortness of breath. And so like they're kind of going back into the history, there's a little bit maybe more there than we initially thought. So it was a good case.
Thanks. All right. Thanks, everyone. Any questions or anything else? Thanks, Nat.
Nick, I kind of have like a general AKI question. It's not actually about this case, but it's been like something I've wanted an answer for a long time.
Okay. I hope I can answer it, but I can't.
Yeah. So
not-
you know, like whenever anybody gets admitted with an AKI, and we're like, oh, let's check urine lights, but then like the ED gave like normal saline, and we're like, oh, okay, we can't check urine lights anymore, or like it won't be reliable. Like I feel like there's a time course when that won't be true and you can check it later. Like I don't know how long the effects of saline would last. Do you have like any idea if there's like an answer to that question?
The only thing I know about urine lights, first, the FINA is really only helpful if someone has really bad AKI, and second, they also need to be oliguric for it to work.
Mm-hmm.
So theoretically, if you give them fluid and they're not oliguric anymore, the FINA won't work in that case. I think whether they're oliguric or not could probably be the more helpful thing.
Right.
The likelihood ratio of a FINA less than 1% is about 3 and 0.3. So it helps you, but it doesn't prove anything, right?
Okay.
So I think the response to fluids is really your gold standard for a pre-renal AKI anyway. I don't know.
Right.
I don't know what the exact, truthfully, I do not know the exact time frame. I just know that they need to be oliguric for you to check it. And if they got fluid and they're not oliguric anymore, that is going to mess up your FINA.
Okay. Yeah, I was just like thinking of like, when we were talking before about just working up an AKI, it was just like something that I thought about and wondered the answer to. So, all right, thanks.
I thought that was more like the giving fluids and it messing up your urine studies was more of a hyponatremia thing, messing up your. I mean, I guess it could theoretically affect both, but like I feel like I'm more familiar with it, and it drives us crazy more with hyponatremia. Like, is there actually anything that says that it does mess up your like evaluation of AKI as well? I know it's like sort of some of the same numbers, but because it's like with like hyponatremia, you're looking like your ASA.
Normal saline has more than physiologic levels of salt. So could it, like when things like ADH being activated from like a salt load being given, it's tough to say, like, is that affecting your sodium reabsorption and stuff like that?
Mm-hmm.
I don't know. And then there's like the, shutdown of like increased like fluid being delivered to the kidneys. So then maybe the pre-renal milieu of hormonal balances that are giving you that AKI is now being corrected. So in that active phase, I'm not sure. I just think like with those like kind of factors combined, I always think of people who have been resuscitated. Now that's a moving target. It would be nice to us to have like that baseline function before we started messing around with stuff.
Right.
So I don't know if it helps me interpret things, but I guess to maybe help answer your question, if the findings on your urine lights is not consistent, like if it's still consistent with a pre-renal injury, even though they got fluid, I would then be more likely to believe that that's true.
That's true.
But if the urine electrolytes are no longer consistent with pre-renal after somebody got fluid, I don't know how to interpret that, if that makes sense.
Yeah, I agree.
That's probably how I would look at it. So even if you decided to get the urine electrolytes, if they are still pre-renal, then that means they are still pre-renal. I think that that's true.
Yeah,
but if they are no longer pre-renal on urine electrolytes after getting fluids, I don't know how to interpret that because that might be just its result.
Yeah, that makes sense.
Yeah. I guess my initial question was like, is there a time later on after the fluids where you can say, okay, I can interpret it fully again? Like, you know what I'm saying? Like the sodium's gone back.
I would say, Mike, the reason you're checking it is probably for pre-renal because for anything else, it's not that great.
Right, and by that point, you'd have your answer.
So then I would say just check it to see if it's still pre-renal. If
right.
It is, great. If it isn't, don't worry about it.
Right, that's true. All right. Yeah, that helps. Okay, thanks.
See you.
Bye. Bye. Good job.
Thanks, guys.
Guys.
Maybe stop the share first. I don't know what's going on. It won't let me in.